Just for others, I received a letter of resignation from Laura. She felt that the scope of this work was not compatible with her time commitment currently at her regular job. So we'll be seeking a replacement in our September pool to start November. Bonnie Hartstein.
Present.
Charles Jaquith.
Here.
Justin Hensley.
Here.
Diana Kraus.
Here.
Julie Lewis. Aaron Lincoln. Sally Snow.
Present.
Sam Vance.
Here.
Vern Walker. So we have a quorum. All right, so first order of business, as we start with every PEDS committee meeting, is a liaison report from all activity in the previous session, plus anything that may have happened prior to this meeting, which is tough since we're the second meeting to meet. So let's start with Air Medical. That's Julie's, so we'll defer that one in her absence. EMS, also deferred in Vern's absence. Education, Charles.
The Education Committee had an interim meeting in Amarillo, and the discussion up there was basically trying to see how we could help the Amarillo area with some of the educational problems they were having up in that particular area. Also, the discussion was still ongoing with the community paramedicine, and nothing other than that.
So we'll have a, you'll notice there's an agenda item that we'll get to last on paramedicine, so we'll come back to the paramedicine issue. But it doesn't sound like anything pediatrics related was of burning import there. Injury prevention, Diana?
Yes, so they held an IP committee meeting workday at Dell on July 31st. They have rolled out a document titled the Hospital-Based Injury Prevention Components. This document is an evaluation of the document will follow in the next few weeks via REDCap survey. And if you receive the survey, please complete it and provide feedback on the document. They also have put together a evidence-based topic-specific injury and violence prevention fact sheets. So it's planning for a meta-analysis of published literature on specific injury and violence topics in an attempt to provide a listing of interventions and programs that are evidence-based, that are promising but needs more evaluation, or are ineffective and/or harmful. So they're in the process of developing that. And the next IP committee workday is scheduled for October 30th in Fredericksburg. Ought to be a good time to have that.
Can you speak to pediatric content of the hospital-based injury prevention component, or questions related to the REDCap survey?
No, I can't. I haven't seen the survey.
Okay.
I believe it covers both pediatrics and adult, or the elderly. But they meet at 1 o'clock today.
Okay, thank you. Next report is medical director, Sam Vance.
So from the medical directors committee meeting in May, they formally endorsed the voluntary pediatric EMS recognition program by the EMS for Children program. I also presented the National EMS for Children reassessment that was completed last year, and there were no significant comments that were made from that. The medical directors they asked for more time to review the pediatric transfer and transport guidelines, and they'll be revisiting those tomorrow at their meeting. And they also discussed the mobile integrated health care or community paramedicine programs, and they are looking to develop a task force to address any training necessary and appropriate testing for that, which I think we should probably keep an eye on as far as integrating the pediatric portion of that. And that's all I have.
Thank you.
Excuse me. Hi, I'm Shirley Schultz from the Air Medical.
Do you want to step up to the microphone?
I'm Shirley Schultz from the Air Medical Committee. I'm sorry I couldn't hear back in the back of the room. And I see Julie's not here to report on Air Medical. But I did want to let you know that the Air Medical Committee is having a special meeting this afternoon starting at 1:30. And then our regular meeting is at 4. And our special meeting, part of the purpose of that is to review the pediatric transfer guidelines so that we can get our recommendations to you hopefully before the end of the GTAC meetings.
Thank you so much. We very much appreciate that.
Absolutely. Thank you.
Sally, do you have contact information to integrate with that document?
Yeah,
Okay.
I'm gonna, Shirley has my number, and she's gonna call me if she has any questions that I can answer.
Great. Thank you. Let's see. Stroke is Erin Lincoln, so we will defer in her absence. Trauma systems, Sally.
Trauma systems last time did not take up any action items related to pediatrics. In fact, the interfacility transfer guideline was inadvertently left off of their agenda, but it is on their agenda for this time, so they will take it up tomorrow afternoon, and I will be there.
Thank you. The RACs, that's Laura's. We will need to reassign that. Given her absence, let's see.
Yeah, I don't have one.
Thank you for volunteering.
Anytime.
And last is disaster planning, Bonnie.
Hi, so at the disaster planning meeting this morning, the conversation focused on addressing Ebola infectious diseases and how the hospitals would respond, appropriate PPE, and appropriate preparedness. Additionally, there was some discussion about legislative efforts to propose legislation to protect EMS when they arrive at a scene of a person's house who may be infected with Ebola, and how they would construct that legislation to protect patient confidentiality as well as, but at the same time protect EMS EMS officials. There was, and I was asked Sally to kind of comment a little bit on, there was an agenda item that was relevant to our committee that was on the original agenda as posted, but then fell off when they had their meeting.
Yeah, I spoke with Eric after their meeting, and he was unaware that the agenda item was on their agenda originally. And in fact, we had not asked for their committee to take up the transfer guidelines because we didn't see it as relevant. So he said he felt like it was placed on the agenda by DSHS staff, and that when he reviewed it, he didn't know why it was on there, so he took it off. So he did not have a plan in the future to put that back on, and we had not asked for them to review it.
Okay. So, Bonnie?
This was going to be on about a different topic, so I'll let you finish your comments on this one.
Oh, no, that was fine. I had a comment on infectious diseases. Were you going to continue that?
No.
Okay. So I do know that one of the designated CDC infectious disease pediatric facilities, and I don't know how many of those there are, but I do know that there's a infectious disease unit at the West Campus at Texas Children's. I don't know what the scope of that is, but I'm wondering if the integration of that discussion could address pediatric transfers with that as well. Is that something you could investigate with the disaster planning effort?
Sure. Now, the disaster planning effort that the first gentleman discussed was really a hospital-based plan. And then subsequently there was the transport, and that was in the legislation that is still forthcoming and is going to take a little bit of time. But in terms of how that hospital is integrated into the decision-making at the state level for hospital prepared list. That I could address.
Yeah, and I think the bigger question is, how does one connect all the dots for pediatrics in any place in the continuum? Where is the legislative effort to support that, and how does that influence what we see as the whole care continuum?
Doctor, the legislation's already written. They're in the rulemaking process right now. It was passed through the 84 session.
Okay.
And it talks about how do we share information with infectious patients, as well as addressing the whole response. There will be exercises later, or drills and education opportunities later this year and into next year from some federal dollars on how to do the transportation of these patients from the time they're recognized to the final treatment center. So there'll be a whole lot more information coming on that, and I know that the whole model is to look at the adults as well as the pediatric patient.
As separate units,
As
separate entities, not just saying
make
we're
sure
aggregating.
it's all one big plan, but if it's an
But
adult
both are
here
addressed.
and if it's a child, and so they're looking at that whole gamut, and I would suspect that it'll be pretty similar in the planning process on how do we move them from point A to point B. It's just separate considerations for the pediatric patient and which hospital they go to.
Okay.
So there's a lot of information coming on that, and I would just encourage the committee, as these dates are rolled out on these training exercises, I think they're 2 days exercises, that you're all going to want to get there to make sure you have some input into the process.
So will the central point of coordination of that information remain the disaster planning committee? Do you?
It's really being handled by the public health part of DSHS. So if you're not signed up for Gov Delivery, make sure you get signed up on, and you'll get all these notices as these training comes out, and I'm sure you'll get the information. There's no doubt about it. And the first formal training, I think, is in December, so there'll be a whole lot more of this at the November meeting, and then it goes into next year, and it's throughout Texas. I think there's 8 different sessions.
So Bonnie, will you remain our liaison and point of discussion?
Yeah, I think so. Maybe we'll tag team a little bit.
Okay, perfect. All right, that takes us then to update on child fatality review team efforts. 2 reports, or 2 items of importance. One is Amy Bailey could not be here today, but she did send a very brief bulleted report. The first is that DSHS recently received a grant from the Children's Justice Act to support 2 full-time coordinators. One would be assigned to a rural area and one to an urban area. They will be announcing which area these coordinators will be assigned after they receive the official award notice. So that's good news. The second is that the State Child Fatality Review Team is currently reviewing and updating most position papers on their website. So please put that on your radar to look for updated versions of that activity. And the third and final bullet point she sent is that the state CFRT will begin working on recommendations for the 2016 annual report in November, so that if there are any members that are part of a current local team, please have this team start working on recommendations. They're trying to disseminate that notification of updating the annual report. She's certainly open to any particular recommendations as well. The other bulleted point here to be model for quality improvement collaboration. That is discussion on a future agenda item, which refers to a quality improvement collaborative. For those of you unfamiliar with quality improvement collaboratives, they are time-limited, goal-directed, very specific aims to activities that are intended by groups of institutions, providers, organizations to drive rapid cycle process improvement for improving outcomes of care. That model that's currently being implemented in Ohio involves several hospitals. We previously attended, we had 2 representatives, one from Dell and one from Texas Children's, that attended that collaborative, and it was really focused on abusive head trauma in children, We're exploring that discussion with the Children's Hospital Association of Texas and hope to report something back in the February meeting. So keep an eye out for that. Any other comments, anything to add to the activities surrounding child fatality reviews or child abuse? Okay. That moves us to our third item, National Pediatric Readiness Project, an update on NPRP activities. Sally, do you want to start with just a brief description for those in the audience that may not know what NPRP is?
Sure. I'm sure any of you who work in hospitals, especially in hospital emergency departments, are familiar with the National Pediatric Readiness Project. In 2013, all hospitals were asked to do a self-assessment on their emergency department's preparedness to care for kids, and when you did that, you received automatically a readiness score with a gap analysis of where you fell short of those things that were recommended for emergency preparedness by the 2009 Care of Children Guidelines for Care of Children in the Emergency Department, which was a joint policy statement from the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association. The next step to NPRP, as we have looked at it from a stakeholder's perspective, is to come up with some other plans, and I'll let Dr. Macias talk about the AAP plan and maybe the ASEP plan. But the Emergency Nurses Association feels like one of the things that most contributes to a hospital's preparedness is the addition of a champion in the emergency department for pediatric readiness. The more commitment you have on the part of the director, the physician director, the nurse coordinator, or whatever, the more prepared you are and the more committed you are to pediatric emergency department preparedness. So what ENA wants to do from a national perspective is create state champion teams so that we have representation from ENA, the ASEP, and the AAP, along with EMS support, family support, and rural support, so that we can establish a resource team for hospitals to go to if they need help with how to improve their readiness score. Everybody with me? Everybody that knows about NPRP? So that's the plan. There is a pilot project that's going to gear up the end of the year where 5 states have been identified through the EMS for Children National Resource Center to start to pilot these state champion teams to see what the roles and responsibilities of the team members might be, and to draft a consensus statement that all of the stakeholder organizations would sign on to talk about the value of a state champion team and have those resources available in every state in the country. Texas is one of the states that does a pretty good job, and we had more hospitals participate in the NPRP than any other state in the country, and we still only had about 60% participate because the NPRP went to 504 hospitals in the state of Texas, and we had over 300 participate. So great numbers, but they could be better. This was a quality improvement assessment, so it was completely confidential. You were the only one who saw your preparedness score. So there was really no good reason not to do it. No reason for fear that other hospitals would see your score. So stay tuned for next steps. We probably, as we always do in Texas, will start a little bit early on developing our state champion teams. And you'll hear more about that. If you want more information about the National Pediatric Readiness Project and its next steps, please feel free to contact me or Sam or Dr. Macias or anyone, Diana, anyone on this committee. We can help you get a head start on what will be the next iteration of the National Pediatric Readiness Project.
So to add to professional society engagement outside of the Emergency Nurses Association, the American Academy of Pediatrics has established a national committee for National Pediatric Readiness Project to help disseminate similar information and to help engage individual institutions for improved outcomes. One of the challenges with the anonymity to the process is it's great, and it provides for an institution to understand how they're scoring without feeling that that their scores are visible to others. But one of the challenges, that also means that we can't reach out to individual institutions to bridge gaps and to push the request for improvement. So creating a construct across the nation that would have an ability for institutions to engage, remaining within this anonymity process, was also considered through AP with a quality collaborative that would allow individual institutions to engage in a very loose intervention bundle, but a lot of that focus would be in training and establishing champions in each state through the state partnerships to train the trainers, concurrent with processes to engage quality improvement champions throughout the country that are trained in improvement science. So how do you conduct rapid cycle process improvement? How do you cluster best practices to more rapidly and efficiently get to strategies that are low investment but high return on that investment? So that initiative is being kicked off in October in conjunction with the National Conference and Exhibit by the AAP. We've had a number of joint meetings, discussions, email exchanges, working in partnership with ENA. Similarly, the American College of Emergency Physicians is also looking nationally at conversations and strategies for better qualifying the terminology, the wordsmithing around a lot of the key elements that define these opportunities. Sally, do you want to go into a couple of details with some of the ASEP suggestions? Or?
ASEP's focus was mostly on development of systems of care and trying to discourage the use of the term regionalization or centralization so that people begin to realize that no one wants to interfere with already established referral patterns for patient care, but to concentrate on the systems of care for emergency care and especially pediatric emergency care, so that there is a way to establish routes for children that need to be transferred to a higher level of care, and how we work together as a system to do what's best for kids when it comes to emergency care. Is that what you had in mind?
Yeah, and I think the other piece that ASEP heavily influences is measurement across adult and pediatric populations, very active in establishing compliance-related issues. So even in our meeting, there was representation at the same nationally organized meeting by the Joint Commission. And so there was engagement at that point to establish at some point in the future at least a learning component to what NPRP was about as a follow-up to that in collaboration with AP and ENA, I believe, as well. The Joint Commission recently had two pediatric training sessions, of which we had representation for one of those educational components that did describe where national pediatric readiness should look like, and that was education for the surveyors. So we anticipate that with that level of uptake, eventually a compliance metric would be defined for Joint Commission around that. But it's really intended to help improve outcomes of care, and I think part of where we are currently on a national effort is to understand how all those pieces come together. But I think that this survey really provided us some very basic information, such as having a champion really influences your outcomes. Any questions or any comments on NPRP?
I just have one thing to add to that. As far as the PEDS Ready data is concerned, We do have the results compiled by region, and we've reported some of that here to the GTAC over the last couple of years. But as far as breaking down all of your regional data, I have gone to several of the RACs and presented that. If your RAC would like me to come and present your regional data, I'd be more than happy to do that, and just get in touch with me.
Okay, thank you, Sam. Well, you're up next. Pediatric Facility Recognition Program.
Oh, all righty. As far as the Pediatric Facility Recognition Program is concerned, just to add to what we've already said, our proposal is finished as far as making a final professional proposal. We are trying to coordinate dates to meet with the leadership of TTAF to present that to them, in hopes that we will have a meeting of all of our stakeholders in the fall or winter of this year to start the strategic planning process. On September the 28th at 10 o'clock in the morning, we are going to be presenting a webinar to the general membership of the Texas Organization of Rural and Community Hospitals, or TORCH. And we will also be presenting the Facility Recognition Program to the Executive Physician Committee of the Texas Hospital Association in January, in hopes of receiving formal endorsement of the program from them as well as from TORCH. And we just recently received formal endorsement of the Facility Recognition Program from Texas Parent to Parent. So, and that is it for the Facility Recognition Program. And I guess I'm up after that, too.
Just a question for you. Is
Okay.
there anything else that you need from this committee? I know we've had several discussions with regard to the Facility Recognition Program, offered edits, et cetera. Where are we now with next stages in engaging this committee?
I think as we move forward, once we have our meeting with TTAF and we set our stakeholder meeting, that this committee would hopefully and would definitely be invited to participate in those stakeholder meetings.
Okay. Then you're up next for EMS for Children's State Partnership update.
All righty. Well, the first thing I wanted to say is congratulations to our EMS for Children Program Manager, Dr. Manish Shah. He was appointed recently by the U.S. Department of Transportation Secretary for a 2-year term to represent the sector of pediatric emergency physicians on the National Emergency Medical Services Advisory Council, or NIMH Sac. And for those of you who don't know what NIMH Sac is, it's basically a nationally recognized council of emergency medical services representatives that provide and consult with the Federal Interagency Committee on EMS, or FICOMS, and the Secretary of Transportation on matters relating to EMS on a national level. And just to expand on that a little bit, I don't know if you're all familiar with, but we have several folks in our state here that are leaders nationally in pediatric emergency medicine and things that pertain to pediatrics. That includes folks right here on this committee: Sally Snow with ENA, Dr. Macias with AAP. You have Diana Krause with Society of Trauma Nurses. Dr. Shaw is back there, not just with the appointment to NIMH Sac, but also with AAP, and NIMH with Dr. Kate Remick, who's on the Medical Directors Committee, and multiple other national organizations. So as far as not only representing Texas here, our folks are also kind of representing things on the national level as well. So I just had to toot our horn there a little bit. So. But as I mentioned earlier, the Voluntary Pediatric EMS Recognition Program was formally endorsed by the Medical Directors Committee in May, and then it was also endorsed by the big council, GTAC, endorsed the program in May as well. So we hope to pilot the program up in RAC A in the Amarillo region in this fall or in the winter, and currently waiting on the funding to come through for our decals on that. Like I said, we'll pilot the program up there and hopefully work some of the bugs out. And we are also looking to potentially pilot the program in RAC E up in the Dallas area. Back in May, we did our EMS for Children Career of the Year Award and presented that to members of the Cy-Fair Volunteer Fire Department, Memorial Hermann Life Flight, and Harris County Sheriff's Office. That was on May 22nd. And in case you don't live in the Houston area, it was covered by all 3 major news stations in Houston, as well as it was in the Houston Chronicle. And I was also told it was on EMS1.com, but I haven't been able to find that. So. Then also on May the 20th, we did a pediatric conference up in Amarillo, the Panhandle Pediatric Conference. And in spite of a disaster drill that we didn't know about that was also scheduled for the same day, we still had about 60 people attend, which for Amarillo, I'm told is pretty good attendance. And so thank you to Derek Vaughn and RAC A for their help with that. We're going to be doing a similar 8-hour conference up in RAC D in Abilene next April. And we're talking with a couple other RACs to do similar conferences there. And if you all would like a conference similar to that in your RAC, just get in touch with me. Let's see. And for now, until I do the other presentation here in a little bit, that's it on the EMSSEE report.
Okay, thank you. Any questions, comments? All right. Next agenda item is, or actually, I'm going to add one thing to the EMSSEE for Children State Partnership. So the EMSSEE, Emergency Medical Services for Children, is the largest funded federal effort for integrating pediatric urgent or emergent care services. In fact, it's the only organization federally that's responsible for that effort. It has pretty much received flat funding, has been anywhere from 21 to 25 million over the course of its inception. So for the last 20-ish years or so?
31 years.
31?
31 years
wow.
now.
No, I do feel old. The gist of all this is that they established 2 centers, one which is a data center that currently is a contract with NEDARC, an organization in Salt Lake City, and the second is a resource support center to support all the state partnership efforts in all states and also any initiatives that may link into research as well. The 16-year history of the existence of the National Resource Center has been is being replaced with a Center for Innovation and
I can look
Improvement. Center for Innovation and Improvement. So it's the EMSSEE Improvement and Innovation Center, EIIC, and that is no longer required to be embedded in Washington, D.C. The reason I mention this is that we, a group, a collaborative effort of people within the state of Texas, will be applying to lead that effort. That effort is intended to be driven by quality improvement and will be funded for 4 years, but will influence the activity in all states with an incredible reach. And I think that as a state, we have a tremendous opportunity to influence the nation and thereby really the world on urgent care and emergent care services for children. So I say that globally because we'll be reaching out to many people that are in the audience, many of the members here. We welcome your ideas. The request for proposals will be posted in October with a very short turnaround time, but we've begun work on that effort. And we really want to see a lot of the wonderful things that are happening in Texas replicated throughout the rest of the nation, but similarly want to take some best practices elsewhere and really change outcomes. So be looking for those requests because we'll really need your support. All right, next item is rules revision, 157. I'm going to take a pause here because our original intent was to review updates to the rules that we had previously commented on. We had met with, I would say, several months ago, maybe even over a year ago, And my understanding is those rules have been revised a few times since then. It seems to be a moving target, so rather than spend a detailed amount of time working on what we sent out, since I know that there are subsequent revisions to even that, we're going to redirect that discussion to a meeting that we will post. So my question is, how much time, if we can gather our schedules within the next 5 days and determine a date, let's say 4 weeks from now, number one, will 4 weeks from now be sufficient time to get the final version of the rules?
No.
So that we're not, no.
So the EMS committee will be meeting tomorrow, is looking at doing stakeholder meetings between now and November. So my recommendation would be for this committee to try to attend as many of those meetings around the state, or at least have a representative there. I know Sam goes to a lot of them. And then when we get closer, Doctor, to a final draft, I would suspect to be a better time for your committee to look at it at that time. So that you're looking at not an early draft, but a final draft. So
And that's, you say, in November.
yeah, the goal would be to have this go to GTAC in November. I don't know if that's realistic or not. It really depends on how much comes out of it. We've had about 6 or 7 or 8 stakeholder meetings reviewing early drafts, but we are still at an early draft. It may, if you want to try to do something before GTAC in November, maybe sometime in October, because the one thing I can tell you from Senate Bill 8, when we were having stakeholder meetings, after the first couple meetings, you're not hearing a whole lot of new stuff. You're hearing the same stuff, and you keep massaging. So if you did something toward, if this committee wanted to do something toward the middle or end of October, that might be a better use of your time.
Okay, that's extremely helpful in being as efficient as possible. If we were planning, 6 weeks should be plenty of time, right, to meet requirements for open
Yes.
meeting postings?
Yeah.
Okay.
Oh, yeah.
So we will target that. I will say that whatever versions we have seen seem to incorporate most of what we had described previously that was attentive specifically to the pediatric needs. So very pleased with that. And so I suspect our October additional meeting will go relatively smoothly. We'll attempt to do that in Austin.
And we'll be posting drafts as we start having stakeholder meetings. My plan would be like we did before, is here's the first draft. As we make changes, just highlight it in yellow where the changes were made, so you don't have to keep reading, because there's 17 chapters being rewritten. So you don't have to keep reading the 17
Right.
chapters over and over. Trust me, my hair was brown when this all started. So I just want to make sure it's still there when we're all done this.
No, it wasn't.
Let me pretend, okay?
All right, thank you. We appreciate that. So that will actually buy us a little time in today's meeting. So let's move to item number 7, which I believe is the same 7. Update on pediatric transfer guidelines, facility transport and review of draft. Anything additional to that? I know that you've got meetings for the other subcommittees.
No, just that there were some minor tweaks made to the guideline after last GTAC meeting in May, and those have all been sent to the chairs of each subcommittee that we felt had a need to weigh in. Most of those committees will be hearing or reviewing those changes or the guidelines today and tomorrow, so we hope to be able to get some approval process in the works over the next couple of days.
Are we still on the big GTAC agenda to present that guideline?
I believe so.
I did send it out, at least the version with the last tweaks. My understanding is I don't, and please correct me if I'm wrong, if there are only minor tweaks by the other subcommittees, those can be expressed verbally and I don't need to resubmit a complete new version.
It looks like it's item 8 on the main agenda.
Okay, perfect. So hopefully those comments will be minor and we'll be able to get it through this. I know that the large committee has been updated at every session for the last 3 sessions.
Right,
So-
and some of the committees have had this on their agenda for a couple of GTAC meetings now, and others are putting it on for the first time this time, so we'll see what happens.
Okay, perfect, thank you. And I will actually not be there to present. Sam will be presenting in my absence.
Great, okay.
All right, so trauma registry update. This was prior Christopher Drucker, Dr. Drucker, and Diana Kraus. Do you want to update on liaison status, et cetera?
So Chris is gone, right? It's effective. He left. He took a position back in Utah.
You scared him away.
So he left as of August 3rd. And so I guess you're here to give us a report?
Yes.
Okay.
Hello, I'm Dr. Nina Leung. Chris did leave to Utah State Health Department.
I'm sorry, how do you spell your last name?
Leung, L-E-U-N-G.
Thank you.
But other than that, we are fully staffed on the registry teams, so it's going to be business as usual for us. In terms of any data updates, the revised report on comparing the pediatric versus non-pediatric facilities that was presented at the last GTAC, the May GTAC, has been updated based on some of the revisions and comments that was given, and is now posted on the injury program website. And in addition, we also have linked 2010 to 2013 TxDOT crash data to trauma hospitalization data now available. And Rose Walker, who's part of the registry team, will give updates specifically regarding the registry.
Okay, can I, and this is a very specific question, it's okay if the answers, you'd have to look at it in more depth, but I have, so in the latest version that we disseminated, we had 13 pediatric facilities that were included in the pediatric portion. I couldn't find the number for the previous version prior to revision.
Okay.
Do you know how many hospitals were changed by designation of non-pediatric to pediatric?
I do not specifically know that. Casey Sile is the one that presented the report, that generated the report. So I will check back with her, and we can get you the difference in those pediatric facilities that were previously presented and now is currently revised.
And it might be helpful along with that process to know what identifier in the data was used to reclassify.
Okay, yes.
Okay.
So for clarity, the issue was that Memorial Hermann and San Antonio were listed as an adult facility.
Correct.
And weren't listed as a specific pediatric facility.
Yes.
And so when we looked at where children are going in the state, it was very much skewed.
Yes.
That a lot of kids are being cared for at adult facilities, which really isn't
The case.
true.
Yeah. I believe that was included in the pediatric facility in this revised report, but I will double check with Casey Sile because she's the one that generated the report.
Okay.
Could you please make sure the report is dated?
Yes.
Because I don't see a date on this report that
Okay.
we had last time.
Okay. I will definitely.
And then
tell
one
her
other
that
question.
edit.
Are you going to be Chris's replacement, our liaison?
Oh, no.
Because I think that would be very helpful for us to understand. Chris was very responsive to trying to help us and resolve issues with the Texas Registry. And so I think that would be helpful for us to understand the structure a little bit.
I can clarify that. I'm Dr. Heidi Boyes. I'm the director of.
Can't hear you.
Keep the mic up, yeah.
There you go.
All right. I'm Dr. Heidi Boyes. I'm the director of the Environmental Injury Epidemiology and Toxicology Unit. And I'm going to be the interim acting manager for the unit until we get Chris's replacement. His job has been posted. It's online. I've received lots of applicants, and as soon as next week I'm going to start interviewing. Nina Leung is going to be the team manager for the epidemiology portion, and Rose Walker is going to be the team leader for the registry operations.
So who is our single liaison contact?
You can direct your comments to me.
Okay, perfect. Thank
And
you.
your last name was what?
Boyes, B-O-J-E-S.
I would just ask, as you do comment, that you can go to them directly, but also make sure you copy Colin into it so that we keep that communications going.
Right, thank you.
And Chris had given me the name of Adrian.
Adrian Condor?
Yeah.
Yeah.
Yeah. And so where does he fit in?
Adrian is one of I'm Rose Walker. I'm a part of the Registry Operations Support Team.
Okay.
It's about 5 of us. It's myself, Tiffany Munoz, right here. Adrian Condor is another, Judy Whitfield. And we have 2 system analysts, and that's Jeremy Reynolds and a new system analyst, Lee Van Cleve. So that makes up for the Registry Operations Support Team. So if you have any questions, you can also email us too, and our email address is injury.web@dshs.state.tx.us. That's for any requests. You can email us there, and we check that daily.
Can you do that again?
Injury.web
Okay, I got it.
at dshs.state.tx.us. So I'm here to provide an update on where we are in the registry. So in terms of NIMHSSEE, we're happy to announce that we are now NIMHSSEE V3.3.4 certified, which means that our vendor now has met standard requirements for the receipt of V3 data. We are currently testing the data now, the record receipt submission. And if the EMS committee, RACs, or vendors would like to submit their records for testing, they can email us that request at the injury.web email address that I just gave you all. And so once that testing is completed, we will notify everyone. And also after discussions with stakeholders, DSHS has accepted recommendations to extend accepting the legacy data. So we'll be accepting legacy data until December 31st, 2016. We're also testing NTDB XML files and new submission feedback report, that's currently being tested. And once that testing is completed, we'll notify all hospitals when the registry has the capability of accepting XML files. We're also testing the NTDB extract capability as well.
So in layman's terms, can you tell us what the additional NIMHSSEE certification would provide in terms of translatable information for us?
Okay, it's where we'll be able to accept the latest version, the different data elements for the V3 that's different than what additional elements than what we capture now. I believe that's your question.
Do you know if there are pediatric elements in that?
So there are some pediatric elements. Specifically,
and I believe Dr. Drucker provided you, sir, Dr. Mensis, some of those elements that she's speaking of, the pediatric V3 data elements.
Oh, that was the document that you're on the agenda for. Is that? Yes. Okay.
Yes.
Okay.
Perfect. Thank you for piecing that together.
Okay, thank you.
yeah.
Doctor, this is a big deal for Texas. We were the last state to come on board, and we are now there submitting nationally. And because of our linkage and the great work the registry did with the hospital, the trauma side, we're only one of now 6 states that can track a patient through EMS and into the hospital. And there's only 6 other states or 5 other states in the nation able to do that. So we went from last to right to the top of the list practically, and we're positioning ourselves really well going forward. And what this will allow, as we submit data nationally, you'll be able to go to the national data, to NIMHSSEE, and start doing reports comparing and looking at like systems in other states. So
yeah, it's huge.
This is a huge step for Texas on doing some real validation of what we do every day.
Thank you. Appreciate that. Diana, did you have anything to add? Okay. Sam, we have additional data and analytics evaluation. So Jane Guerrero had sent out some information on pediatric tools utilization. And Sam, I believe you've summarized that for us.
this than I did. So the way I understand it, DSHS sent out a survey to all the trauma centers as they are working on revising the trauma regulations. Is that correct, Colin?
I believe so.
No? Either way, yeah, either way, there was a survey sent out to the trauma centers to determine if they carry Broslow tapes and the Broslow crash carts in their emergency departments. From this first slide, you can see that there was participation of 190 trauma centers throughout the state, or 100% participation, with the majority of those being the level 4 centers. And as you can see that almost 99% of these facilities do treat pediatric patients in their emergency department. And you can also see that 100% of them have Broslow tapes located within their emergency department. One thing I want to point out with the Broslow tapes is that, as I have found in the past, some folks don't always have the most recent version of the Broslow tape, and you should have the most recent version of the Broslow tape, which right now is the 2011 edition A. And from this slide, you can see that that they are using the Broslow tape for pediatric patients in their emergency department. Again, roughly 99% of them are. But one thing to remember about the Broslow tape, the Broslow system, is that it is only for those pediatric patients who require resuscitation or emergent stabilization. It's not to be used as a standard method of estimating weight in kilograms. And you can see that about 94% of our trauma hospitals also have the Broslow color-coded storage system, or the crash carts. So this kind of coincides with the PEDS Ready project, and one of the things that has been identified from the PEDS Ready project is that weighing and recording children in kilograms is the most important safety initiative for children. The National Resource Center just put this out within the last couple weeks, that only 1 in 2 of our hospitals across the country actually weigh and record our children in kilograms. And the reason for that, the reason why this is important is because of the high risk of medication errors and the serious consequences as a result of the errors. Because like in adult medication doses, those are often standard unit doses. We give 1 amp of epi, 1 amp of this, 1 amp of that. But in kids, it's weight-based, as we all know. 1 milligram per kilogram, or 0.01 micrograms per kilogram. And there are a lot of errors with that. Particularly one study showed that out of 479 medication errors, that over 25% of those errors were due to confusion between pounds and kilograms. So weighing and documenting pediatric patients only in kilograms has been repeatedly recommended in the literature as a strategy to decrease medication errors, not only in the emergency department, but throughout the entire patient encounter. So our PEDS Ready data here in Texas shows that the national average was 56%. Here in Texas, only 51% of our hospitals weigh and record the pediatric patients in kilograms. This shows the percentage of our hospitals by RAC that weigh and record their pediatric patients in kilograms. RAC-T did not have enough hospitals respond to the assessment. That's why there's no data for RAC-T. So this shows our trauma centers that weigh and record in kilograms. And as you can see, our level 1s, 82% of them weigh and record in kilograms, level 2s, 69%, level 3s, 54%, and level 4s, 38% of them weigh and record in kilograms. So the Emergency Nurses Association position statement, which was also endorsed by the American College of Emergency Physicians, the AAP, the Institute of Safe Medication Practices, and the American Academy of Emergency Medicine, Society of Pediatric Nurses, their position statement is pediatric weights only should be measured and documented in kilograms. Scales that are used to weigh pediatric patients should only be configured to record weights in kilograms. Pediatric weights are recorded in a prominent place on the medical record. Electronic medical records should be standardized to allow only kilograms for pediatric weight entries. The pediatric patient's actual weight is considered part of the mandatory nursing assessment. That pediatric patient who requires resuscitation or emergency stabilization should use a standard method of estimating weight in kilograms, which is the link-based system. And then the pediatric patient's weight in kilograms is included in an inter- or interdisciplinary patient handoff report. Then the last thing that I just want to point out that is similar to the Broslow system that is starting to become very popular here in the state of Texas with our pre-hospital folks, it's called the Hantevi system. It was developed by Dr. Peter Hantevi out of Florida. It is an alternative to the Broslow system. They are looking to implement this up with Dallas Biotel. I believe CETRAC and RACQ is also looking to implement this, and there are numerous departments throughout the state that are already using this system. Essentially what it is it takes the math and the guessing out of it. It is for weight and age-based, and I'm not 100% familiar with it to explain it to you, but it is used by using the hand, and each finger represents a weight and a dosage. So I just wanted to bring that to your attention. Like I said, I'm not an expert on the Hantevi system, but it is out there throughout the state. A lot more folks are starting to use it, and you will probably be seeing it in your emergency departments.
Sam, do you think that it might be possible to have one of our EAC members, Dr. Wong, Craig, report back on their use in Dallas?
I don't know if they're actually using it in Dallas yet. I know they're looking at it. Yeah,
Okay.
yeah.
So, Sam, is there a cost? I guess I would be curious as to why we would move away from a standard of the Broslow tape to this. Is it cheaper? Is it easier? I mean, what's the driving force?
As far as the cost is concerned, I don't know what the cost difference is. It is supposed to be easier than the Broslow system, faster, more accurate. There was one study done comparing the Hantevi system to the Broslow system. I don't know what journal that was produced in, but it basically showed that the level of accuracy that pre-hospital personnel had with this system versus the Broslow system was better. Our position is whether you use Hantevi or Broslow, either way something that kind of helps take all the math out of it and is a good system.
Okay, well, it sounds like that requires a follow-up and
sure, and I can definitely
February.
find somebody to do it. I know Washington County EMS uses the Hantevi system. Perhaps we could have someone from their organization come and talk to us about it.
Okay. All right. Anything else on surveyor tools?
Dr. Macias, can I just,
Yeah.
I'm going to pull Eric Epley. How many of you guys in the audience do not require pediatric weights to be recorded in kilograms? Is there anybody out there that doesn't require pediatric weights to be recorded in kilograms? How is it that only 51% of the people surveyed?
None of those people are here.
Yeah. Well, clearly we're not the most popular committee to attend anyway, but that's amazing to me. One of the things that the Emergency Nurses Association, who developed that position statement, has asked their members to do is not to even discuss weights in pounds with parents. They want to know what the weight is in pounds, but if you will talk to them about why it is so important that they know their child's kilogram weight and never tell them anything about pounds. If you want to have a conversion chart in your triage area or whatever and let them convert it themselves, but if you as a nurse never, or an EMS provider, never talk pounds, You won't go to the record and record the wrong weight of measure. So don't talk about pounds to them, but tell them why it's important that they know their child's kilogram weight. Really important that we do that.
Thank you, Sally. So I think our last agenda item is really just an introduction to future discussion, and that's paramedicine scope for pediatrics. Part of a prior discussion was that we wanted to be supportive of the other committees that have brought up the discussion for paramedicine and scope of practice, wanted specifically to look at pediatric initiatives. So my request for Sam and Charles Jaquith is, can we look at the EMSSEE initiative that looked at paramedicine scope for asthma management and get some kind of report for our next session? And then perhaps within that context, we can discuss other efforts with the other committees.
Yeah, we can do that. In addition to the one that targeted issues grant that's there in Indianapolis, I know that Children's Medical Center in Dallas is also working with the Dallas Fire Department on a similar program. And then on the national level, I believe it is the state of Michigan that has also implemented a program, a pediatric program for mobile integrated health. And the Pediatric Emergency Care Council of NIMH has developed a subcommittee to start developing guidelines for pediatric mobile integrated health care. And we'll be talking more about that in our fall meeting, which is in November. So I can report back on that if you like.
All right. So national efforts and best practices, if the two of you could work on that jointly, that'd be great.
Sure.
Thank you. All right. So that is everything on our agenda. Any comments by any of the members? If not, I'll briefly review sort of next steps and charges for the group. All right, so I have one transfer of liaison functions, and that is yours for the RACs to replace Laura Friend. Bonnie will follow up as our liaison for infectious disease with the efforts that we heard previously for disaster planning, specifically to understand the pediatric continuum. We will have an update in February on the quality improvement initiative for abusive head trauma once those discussions are better solidified with the Children's Hospital Association of Texas. Sally and I will bring back any updates on National Pediatric Readiness Project as well at the next meeting. The Pediatric Facility Recognition Program, Sam will give us just a brief update of any changes, any additional endorsements that occur in November. And is the webinar to the general membership of Torch available to others, or is it specifically to Torch?
That's a real good question. I would have to, I guess, look at their website and contact their leadership.
Okay.
But
if that is...
I would guess, but I don't honestly know.
Okay, so we'll follow up on that. EMS for Children State Partnership will have our routine update in our next session. Rules revision, I'll send out a request for meeting times with the intent of aggregating a meeting in Austin for mid-October. I will send that information to Colin to get that posted to meet our rules requirements for posting in the next week or two. Update on pediatric transfer guidelines. We should have our revisions to present as item 8 for the big GTAC meeting on Friday. So hopefully we'll be able to have that approved in this session. Trauma registry update. We now have our liaison, Dr. Boyes, and I apologize if I'm not pronouncing that correctly, who will be the liaison to these reports. Very excited about the work that that has been added and the additional capabilities. And we have a paramedicine scope discussion in our next meeting. I think that's everything. Any public comment, questions? All right, so we are adjourned. Thank you.